Vera Hooperts, and this is put on today from Solutions for Patient Safety and the Joint Commission Resources. My name is Missy Shepard, and I'm the Executive Director for Solutions for Patient Safety. And today I was supposed to be joined by Deb Nadsum of JCR, but unfortunately she lost her husband over the weekend, so she's not able to join us. But all of our thoughts and prayers are with her as she's going through this tough time. So again, our speakers are Vera Hooperts and Rachel Wentz. Vera is the Medical Director of Pediatric Hepatology and Transplantation and the Vice Chair of Quality and Safety at the Cleveland Clinic Children's Hospital. And then Rachel is the Assistant Vice President of Quality Improvement at Cook Children's Healthcare System. Here's a quick look at our agenda for today. I'm going to go through our objectives, and then Rachel's going to do a patient story, safety story for us. And then I'll give you a little overview of SPS for those of you that may not be familiar with our organization. And then Rachel's going to talk about preventing CAUTIs in pediatrics. And Vera's going to go through our operational definition and give you an update on our SPS outcomes. And then Rachel will talk about prevention bundles and high reliability theory and cover some of the top interventions for pediatrics. Then we have a couple questions for you as a group, and then we'll open it up for discussion. And when we open it up for discussion, the way that we'll do that is ask you to put your questions in the chat box, and then we'll unmute you and call on you. And you can put questions in there throughout the webinar as well. So our objectives today are to give you a little bit of an overview of SPS as a pediatric safety learning network. Help you understand pediatric CAUTIs. I think most of you, we looked at the registration list, and a lot of you are with pediatric hospitals, which is great. But we want to share with you our experience as a learning network and how we've worked on building the evidence for SPS prevention standards for CAUTIs. We want to share some of our best practices and top interventions for preventing CAUTIs in pediatrics, and then share our application of high reliability theory to achieve the desired outcomes. So with that, I'm going to turn it over to you, Rachel, for our patient safety story.
Sounds good. Thanks for attending the call today, everybody. We like to start our meetings and some of our different online meetings with just different safety stories, just kind of our call to action of why we are doing what we're doing. In this particular safety story, I borrowed from our PICU, and they had presented it to staff in kind of an SBAR format, so that's the way I've copied it over for you. But what had happened was we had a patient on our PICU who had received an order to insert an indwelling urinary catheter for strict INO monitoring, which is one of our clinical considerations. And the bedside staff had been educated on the insertion bundle, and one of the biggest points we had driven home here at Cook, one of our biggest opportunities for improvement was around the cleansing of the perineal area with soap and water prior to using the betadine that came in the kit. We found that when we were doing just the one-on-one observations with the standardization of our bundle, that was one of our biggest opportunities. And so that training had taken place. And as the nurse and the care partner were in the room, the care partner was kind of that team member check, observing the insertion, and noticed that the nurse was starting the process without using the soap and water. And so she used what we call Stop and Resolve, which is one of our error prevention tools that Missy's going to talk a little bit about, just the high reliability principles. It stopped the nurse, felt empowered enough to stop the nurse, and gave her the supplies that that nurse needed to continue, the soap, the water, some 4x4s, and reminded her of the process. And so we were able to stop a potentially unsafe event by someone speaking up. And then the recommendation from that team that was involved, so the nurse and care partner, was that we educate the rest of the staff and just give them a heads up in our weekly communication of a gentle reminder of practice. So lots of great, this is like one of those great safety stories. Sometimes we share adverse events, but lots of great happenings here. We had a care partner empowered enough to speak up. We had a nurse that thanked her for speaking up and recommended that we share the learnings with others so others didn't make that same mistake. And then we stopped a potentially unsafe practice.
Thanks for sharing that story with us, Rachel. If folks on the webinar and phone have any questions about that safety story, again, you can use the chat box for that. So I'm going to give you a little bit of an overview about SPS, which is the acronym that we use for Solutions for Patient Safety. We're also known as the Children's Hospital Solutions for Patient Safety. Our mission is working together to eliminate serious harm across all children's hospitals. Our goals for 2015 and 2016 currently are we're working for a 40% reduction in hospital-acquired conditions. We also call this HACs, a 10% reduction in readmissions, and a 25% reduction in serious safety events. We also call those SSERs or SSEs. We started out as a network in the state of Ohio with the 8 children's hospitals in Ohio, and since then we've grown. Back in 2012, we became part of the Partnership for Patients program, which allowed us to scale our work from Ohio to a national level. And then more recently, we just added our first hospital in Canada, Sick Kids. So we have spread. We are now a network of 87 children's hospitals and still growing. We have a waiting list of hospitals that would like to join in July. Here's a slide that has all of the logos of the hospitals that are in our network currently. And our hospitals represent a little bit over 50% of pediatric admissions across the U.S. And continuing to grow, but there's still so many more children that are being seen in other hospitals. So our goal as a network is to share our best practices so all of the children can get the best of care. Our approach, we try to engage our membership hospitals at all levels. Leadership matters. Having that buy-in at all levels of leadership within an organization is critical for this work and to get the desired outcomes. Our mission motivates all that we do. We start every meeting with that mission, as well as sharing our latest outcome data. And one of the biggest principles in our approach is that we will not compete on safety. We're an all teach, all learn network. We believe that every hospital has something to teach, and we all have something to learn from one another. And all of our hospitals commit to build a culture of safety. So this slide represents our approach. As you can see, the hospital-acquired conditions, or HACs, that we're currently working on are showing up in the downward arrows. And you'll notice that they point towards our 10% readmissions reduction goal and our 40% hospital-acquired condition goal. And across the sideways are our culture domains, or the work that we're doing. We believe as a network that we're not going to be able to get the desired outcomes for those hospital-acquired conditions without addressing the culture. So we do a lot of work around safety governance and cause analysis, as well as teaching leadership methods and error prevention techniques. And we involve families at all levels of our work, and we're continuing to do that and hope to do even more with family engagement because of its importance, as well as working to build high reliability units and having a just culture. So this is our approach. To continue that, we decided as a network we needed a way to have new work come into our system, as well as be able to get enough evidence and great information that we can spread to all the other hospitals. So you'll notice that the discovery phase of our network is where we have new work coming in, and that's actually work that's happening outside of our network, or it may be work that our hospitals are working on that hasn't been brought, but they have a good idea that it's a harm that we should be addressing. Pioneer is where we don't have the evidence or the standard prevention bundles built yet, so we ask our hospitals to volunteer and do a little bit more observations and more testings and PDSA cycles. And then once we have the evidence or have enough to build the prevention standards, that's when a particular hospital-acquired condition or a culture aspect of our work goes into what we call an aviator phase. And that's where we are sharing today. CAUTI falls under our aviator phase. So we're sharing what we found as evidence in our network through lots of testing and observations for CAUTI and preventing CAUTI. And then orbiting is for the HACs that we've met or exceeded our reduction goals, and it's kind of like a sustained phase where we're monitoring for performance. And Explorer is where we want to spread all of our information to all of the other hospitals to prevent harm from happening for children. So this slide represents where all of the downward arrow HACs fall within our design for our network. So you can see in discovery currently we have unplanned extubations is going to be our next set of work for HACs. And for our culture work, second victim and employee safety and situation awareness are our next topics that we're considering for Pioneer for culture. ADE, VTE, readmissions, OBAEs, and PIVs, or PIV infiltrates, are in our Pioneer phase. And you can see family disclosure is part of our Pioneer for culture. And then Aviator, which we're covering today for CAUTI, we have surgical site infections, pressure ulcers, central line associated bloodstream infections, CAUTIs, or catheter-associated urinary tract infections, and VAPs, or ventilator-associated pneumonias, as well as our cause analysis, air prevention, leadership methods work is an Aviator. And then Falls is an orbiting, and Explorer is where we start sharing all of our operational definitions and prevention bundles. So with that, these are our Aviator hacks, so surgical site infections, serious falls, pressure ulcers, CLAPSIs, and CAUTIs, and VAPs. So how are we doing as a network? So on the screen currently, you can see our reduction in the hacks that we've been working on since 2012 as a network. Falls is where we've seen the most significant reduction of 81%. And CAUTI, which we're talking about today, we've had a 25% reduction. And the items that you see in the boxes are actually the hacks that we've been working on as a network, but we actually saw increased detection. So we are just now starting to see reductions for those three conditions or projects. And this actually shows you the return on investment, or the harm averted, the costs that would have been associated with the harm. And as a network, to date, we've saved over $61 million. And with that, I will turn it over to Rachel, and she's going to talk about preventing CAUTIs in pediatrics.
Thanks, Missy. So I just want to go ahead and go to the next slide by introducing you to our team. Each of the hospital-acquired condition or HAC teams with the Solutions for Patient Safety, or SPS, has co-leaders that are just members from different hospitals, from the Pioneer or the Phase 1 hospitals, and then we have a team dedicated to us from SPS. And so Vera and I are the co-leaders for the CAUTI, and we have support from our teams as well. Kathy Ackerman and Dr. Charles Foster from Cleveland Clinic, and Lisa Schlafly and Dr. Joanne Sanders from Cook Children's. We attend monthly calls to just analyze the data, look at best practice, discuss questions that are coming up with member hospitals, go over discussion board items, talk about next steps. And each of the hacks follows this methodology to continuously improve, continuously look at the bundle elements, analyze the information we have around the bundle elements to make sure we're making the right moves and decisions as a network. And our support team from SPS for this particular, is Sherry Wooten, Matt Short, and Aaron Goodman. And so we want to talk a little bit about defining the HAC problem in pediatrics. So one of the most common infections in the hospital is a catheter-associated urinary tract infection, or what we're referring to as CAUTI. And as the people on the call probably know, but we wanted to include it, caused by germs that enter the body via the urinary catheter, and that the infections can lead to serious complications, including death, especially for critically ill patients. So something we want to avoid for sure. Next slide. And we know that 80% of these are associated with an indwelling urinary catheter, which is that tube, which is why, again, we're focused so much on CAUTI and not just generalized UTI. Because with CAUTI, we can prevent the UTI by not having the catheter present in the first place. Go ahead and go to the next slide. And when we look at what makes CAUTIs unique for children, you know, the definition from the Centers for Disease Control is pretty much the same unless you look at the kiddos that are under a year of age, and those have some additional symptoms to help call it a CAUTI at the end. But there's some other unique factors that when we look at kids, not just the way we're calling the definition clinically, but the way it's treated, the way it's exacerbated, and the way we approach it from a nursing and clinical standpoint. First, kids have a limited cognitive ability to understand prevention of an infection. And so this is kind of a unique factor for children, especially those that are younger, that we can't explain what's going on, why the tube is in place, how to, you know, not touch it, not play with it, how to keep it below the level of the bladder. They play on the floor and other dirty places. They're very mobile. They're not going to sit still as they start to feel better. And so there's an additional factor in there around prevention. Also, kids wear diapers. They move around more than adults. They wear diapers. They're incontinent. They're involuntary of stool, so we have some added risk there. And they don't have the same hygiene as adult patients. Next slide. Do you want me to keep going, Missy? Oh, sorry.
Can you hear me?
Yes.
Can you hear me? This is Vera.
Yes.
Oh, okay, great. Thanks. All right. So I'll go ahead and talk about the key driver diagram. We obviously realized that this was an issue and an important issue in working with children. So the first thing we got together as a hack team and we came up with a key driver diagram. And we did this by actually having all the members of the different hospitals get together in one of our learning sessions. People sat around and said, well, how do CAUTIs occur? Why do they occur? So as a result, we came up with key drivers as to what causes, what we thought were frequent causes of CAUTI, and then we came up with a list of interventions. So our SMART aim, as Missy said earlier, was to decrease the CAUTI rate by 40% by the end of 2016. So one of the key drivers that we looked at was to achieve reliability with a CAUTI evidence-based prevention bundle, and to achieve that reliability so that it hopefully would be above 90%, because we did see that the hospitals that had greater than a 90% reliability had lower CAUTI rates. So that was an important factor for us. First thing we had to do was come up with our bundle, and we went through a number of different ways to do this, but what we did was literally look at the groups, all the groups who submitted their bundles, and see who were the top performers and selected out the best of the best, if you will. So we implemented bundles for insertion and maintenance. And then we established measures, or our ideal of getting a 90% reliability to following that bundle. And the hope was that individual hospitals, if they weren't achieving 90% reliability, or if they were having a CAUTI rate that wasn't as good as they would like, they would do PDSAs, Plan, Do, Study, Act, and change the management cycles to increase their reliability for care. One of the other key drivers was a rapid and accurate detection through surveillance, and that also utilized not only your infection prevention teams at your individual hospitals, but also making this as a high priority among the team members, the frontline staff, if you will, so that people would be aware of it, so that everyone could identify when a CAUTI occurred and evaluate it and look for possible causes for each individual event. Sort of, if you will, doing a root cause analysis on those cases. One of the huge things, we've said right from the beginning that is, if you don't have a catheter, you can't get a CAUTI. So the key driver was a reduction in the indwelling catheter days. And there are a number of ways you could do that. Reviewing daily the necessity of the catheter and getting it out as quickly as possible. And many hospitals had different techniques or avenues of dealing with this. And then also avoiding unnecessary catheterization through written clinical indications. And some hospitals may even have nurse-driven removal protocols and algorithms that they use. So we thought that those were all important things, and those are kind of some of the things that we teach at some of the learning sessions, and then hopefully learn from each other. How are you doing that? What mechanisms are you using to do that? Are you using the electronic medical record, et cetera? And then lastly, use of high reliability methods and getting a whole team approach to this. So making sure that there's a high awareness among the teams in the hospital, and also, getting families involved to help, learn how these catheters should be taken care of in the hospital, be the monitors, if you will, and watching out for their own kids, their children's safety as a result. Next slide. So what is our operational definition? Well, we use the NHSN definition from the manual for detecting and for reporting catheter-associated urinary tract infections. Next. Our inclusion criteria is all children admitted to an inpatient unit where it is defined as inpatient or under observation at the hospital with an indwelling urinary catheter. Observation patients who are admitted to observation units and those admitted to the NICUs, the neonatal intensive care units, were going to be excluded. And for most infections, it means an infection doesn't become, or infections that occur after 48 hours unless they are under special circumstances. Next slide. So there are changes to the NSHN criteria that were that came out in January, with which we have accepted as well as part of our definition. So the highlighted changes include the definition that colony counts of less than 100,000 per milliliter will not be counted, and so we think that this will actually probably reduce the number of CAUTIs that are reported. They will not be based on urinalysis results, and urinary cultures that are positive for yeast, mold, fungi, or parasites also will not be counted as urinary tract. The other change that may actually increase the number of infections is that the infection window period will be, essentially a culture done 3 days before and within 3 days after the urinary catheter is placed. That actually may increase our numbers. With regards to symptoms, dysuria will no longer be used to meet the infant criteria, and as our core temperatures will no longer be required for infant fevers. Next line. And then there are some, next page, then there are some specific operational definitions where they differ from adults, especially in children a year of age or less. And that has to do with symptoms that can be used to help make the definition, and that includes hypothermia, apnea, bradycardia, lethargy, vomiting, and suprapubic tenderness. Next. So we have a definition, and how do we calculate our events? So the events are reported as events per catheter day. Our numerator are all the patients contracting an infection as defined by CDC guidelines. And then we put that over the total number of indwelling urinary catheter days during that same time period. And that gives us the number of urinary tract infections per 1,000 catheter days. We also look at the number of catheter days per patient days, because we felt that if you're having a lot of catheters, obviously that's going to increase your catheter. That's a good potential for increasing your catheter infection rate. But also, many hospitals were really working on decreasing catheter days. So for us to monitor this, we could, if you decrease your catheter days, but you may have a couple of infections, your rate may actually go up. So we thought it was important for us to monitor those hospitals that were really working on decreasing catheter days and recognizing that as a win for them as well. So we look at catheter days as the numerator, and the denominator is the total number of patient days, excluding the NICU, giving us the number of catheter days per 1,000 patient days. Next slide. So our current outcomes, we're really pretty happy with what's been going on. And you can see this graph. It starts back in 2012, when we had a rate of about 2.5 infections per 1,000 catheter days. And then subsequently, and around September of 2012, we had a drop in our rate so that it's just below the rate of 2 per 1,000 catheter days. During that whole time period, we've had several learning sessions that were done. We came up with our bundle recommendations at that point in time. So that was occurring as well. We had challenges, for people to, how can you improve your reliability? And we were asking groups, to report more of what they're doing and their reliability to following on the bundle. And so then January 13th to September of 13, we focused on increasing the reliability. And then in June of 2014, we released basically what we felt was a standard bundle with standard elements that all hospitals who belong to the collaborative should be following. And subsequently focusing, this is one of those hacks that we're focusing on the 1 at 90, trying to reach 90% reliability in our bundle, in following the bundle. And we're hoping that we may soon be due for another rate change. If you can see that the last couple months we have 4 dots below the yellow line. And if we get 4 more dots down there, we probably might have a rate change as well, and we'll be very happy with that. Next slide. Rachel.
This is Rachel again. I'm going to talk a little bit about the prevention bundle and just a high overview of high reliability theory. So we know, or what we're practicing under is the assumption that as we raise our reliability to process metrics, standard bundles, that we're going to yield a reduction in outcomes. So we know that if we follow a standard bundle consistently in an all or none approach, that we'll have a reduction in the adverse events that we want to see. But what the question becomes is, what do you standardize? When we started with this journey, when the phase 1 cohort came onto SPS and we talked about just getting reliability measured somehow, somewhere, some way, we asked every hospital to submit data on bundle metrics, no matter what their bundle was, because we found there was a lot of variation from different institutions. But we wanted to measure somewhere to get started. And then after some time, we were able to pull together that data and say, okay, of the hospitals measuring these interventions, what were their outcomes, and how did we compare, and how do we narrow down to the prevention bundle elements that we want to become the process? Next slide. And as we know from literature as well, implementing the prevention bundles reliably leads to reduced outcomes. Next slide. So what does that kind of look like? So when we look at eliminating serious harm in healthcare, we look at, and this chart, what you see is the risk of harm plotted against the improvement over time. And there's 3 different key areas that will help get you to reliable factors. The first is reliable key process design. This is using your evidence-based best practice. This is using process bundles and tactical improvements, using the adage of focusing and simplifying, having less people do standard work so there's less room for variation. And then we move up into high reliability culture. And so the network is really focusing in both of these areas. We're trying to establish what's the best practice to follow. And in pediatrics, sometimes that evidence isn't as well published as it is in the adult world. We're taking what we can from there, we're taking what we can from other institutions, and then we're studying in the pediatric environment, how does this all relate and work together? We're combining that with the whole high reliability culture. And this is where we have set standard behaviors that have expectations across the board. Hiring the right people for your team, hiring for fit, practicing a just culture or fair and just accountability. And we've used the error prevention and leadership methods technique by taking these standard behavioral expectations and rolling them out through our entire institution and saying every employee in these healthcare institutions is expected and empowered to speak up when they see something potentially unsafe about to happen, or is expected to have each other's backs or to ask for help when they need it by using these different 8 behavioral tools. And then even up further than that, where healthcare is not very strong yet, is the human factors integration. So making it impossible to do the wrong thing. So for example, if you think in the OR, it's impossible to hook the wrong gases up to the wrong tubes. Or if you think in the airline industry, the way you turn the light on in the bathroom is by locking the door closed. They did that because people weren't locking the doors in the bathrooms on the plane. And so if you connect to those things, you make it impossible to do the wrong thing. So next slide. So as we look at the different interventions and how we're going to build our bundles, we look at what has more reliability, what puts us in those higher reliability or even making it impossible to do the wrong thing so that we can standardize our approaches. And so analyzing the data from the different hospitals, we came up with a recommended bundle for care around CAUTI for both insertion and maintenance, which you'll see on the next slide. And so for the insertion bundle, we simply have use aseptic technique for insertion, and we describe that out using the CDC references and avoid the unnecessary catheterizations. Like Vera said, if you don't have a catheter, you can't have a CAUTI. What we did not standardize was the written clinical indications. Many of our hospitals actually follow written clinical indications. We do here at Cook Children's. There's not great evidence in the literature of what specifically those clinical indications should be for pediatrics. So as a team, we decided not to actually standardize the written clinical indications, but just standardize the avoiding of the unnecessary catheterization. Our hope is through studying this and getting enough data from different member hospitals, we'll be able to come back and say, These are the top 12 clinical indicators to catheterize for. And then our maintenance bundle has several elements. First, it's maintain a closed drainage system, maintain hygiene, keep the bag below the level of the bladder, and we spell out specifically don't rest the bag on the floor, maintain unobstructed flow, and remove the catheter when no longer needed. So those are the standard elements that we're asking every hospital to follow 100%, not some of the elements, but all of the elements as a bundle every time and measure their performance towards that. We also have recommended elements under the maintenance bundle, and for this it's to secure the catheter. The reason this one was recommended is when we looked at the data, we weren't finding that our high performers were necessarily utilizing this element, but we didn't find that they weren't utilizing it. And so we know that it's a best practice just from our own practice and from looking in literature. We just didn't have enough data to really support it. Next slide. And so we measure both bundles' reliability. We measure both the maintenance and the insertion bundle, and you'll see on this chart the insertion bundle. And let me explain why the graph kind of starts at the end of 2000 or at the beginning of 2013. We had, when we started, like I mentioned, we asked just measure what you have in place somehow, some way, and submit data so we can start studying it. And so when we began this journey, we had everyone submitting their data for both insertion and maintenance together. And so then in January of 2014, we went ahead and separated it. We told hospitals to start separating their data out so that we could study more where are the infections occurring. Are they occurring more on insertion or maintenance? Or where are we deviating more from the bundle? Or where are our biggest opportunities as a network to educate and learn from each other? And so you'll see at the bottom, it tells you how many hospitals submitted reliability data. We had 1 or 2 hospitals that actually went back and resubmitted their data for those time periods to fill in and break out their insertion and maintenance data. But then going forward from December of 13 forward, we actually had this as separate interventions where they could enter their data separately. So what you'll see here is that blue line is our group reliability to the bundle, all of our SPS hospitals that are submitting data. And down at the bottom, you'll see how many hospitals are submitting. What is our rate? Our goal is 90% or greater. We believe that following a bundle in an all-or-none practice 90% of the time will lead to reduced outcomes. The yellow line is our network center line, so what's the group average? We're about 83% there. And then again, that green line is our goal line. So higher is better with bundle reliability. Next slide. And then we also measure this to maintenance. And so the same thing, you'll notice that there was a hospital that was able to go back, or a couple hospitals that went back and submitted their data that they'd already had and pulled it out separately. But as going forward from December of 13 forward, we're able to pull out the data separately for maintenance and insertion. And you'll see that our maintenance bundle average is lower. Our network center line here is closer to 69%. And that's kind of what we proposed already. I think most of the hospitals agreed that when we looked at this, our biggest opportunities would fall in the maintenance. Insertion's a one-time thing. Maintenance is ongoing. Insertion, you can use a checklist. Maintenance is kind of more nebulous. So we proposed this would happen. But what's exciting is that you'll see that variation is starting to decline. We're starting to believe that this data is very reliable and accurate because it's very consistent month to month. So our next goal is to start to bring that consistency up. So we want to see that number go up above 90%. Next slide. And so what you'll see is, again, if that bundle reliability is greater than equal to or greater to 90%, that we'll believe we'll see a reduction in CAUTI. And you can see the correlation here. As our variability decreased and our center line or average increased, that's when we started to see the variability decreasing in our CAUTI events, and we started to see a reduction statistically significant enough to reduce the center line or overall average. So we had enough points below our average to say, you know, this isn't just a back and forth every month where we're seeing maybe a little bit lower and a little bit lower. This isn't just trending down. This is statistically significantly lower, so we can say our average has declined. So that's always very exciting. But also exciting is that those red lines are getting closer and closer together. So the variation in our practice is going down. We know that we're doing things reliably, we're doing things more standardly, so we can almost trust the results more, if you will. Another thing we found when we studied this data to recommend our bundle elements was that when we looked at the funnel charts to compare outcomes to interventions, overall the hospitals who reported following a bundle had improvement in their CAUTI rates, meaning they had less, or that number went down. So it was very exciting just to kind of support the idea that following a bundle, watching what you're doing, paying attention to it, having mindfulness was going to help reduce the number of adverse events you had internally. So it kind of goes back to if you need to start somewhere. Doesn't have to be perfect. One unit, one nurse, one patient, whatever it looks like. Starting somewhere was showing improvement for all of the hospitals. Next slide. So we're just going to go over a few of the top interventions, again, for specific to this pediatric. So next slide. Again, we developed the reliable pediatric prevention bundles for both insertion and maintenance based on evidence-based practice and based on the data that we were measuring. Our reliability measures focused on learning, so observations versus auditing. We didn't want to just go back into a chart and look for days later as to what happened, but we wanted to watch practice and day-to-day, especially with the CAUTI, as we kind of talked about before. You know, you can walk into a patient's room and visually see what's going on, but then that patient doesn't just stay still in the bed. They get transferred maybe to radiology, transported other places. They get down maybe and play on the floor. They're moving around, and so we want to make sure, especially here, to empower families and parents to know what are we looking for. Why is it important to keep that bag below the level of the bladder? Why is it important not to play with the Foley tube? And you can only really get that data through observations. And again, avoid those unnecessary catheterizations. We believe that's the best practice by having some written clinical indicators and following that. And then some of our member organizations also utilize a nurse-driven removal protocol. So standard orders that say, if this and when this happens, do this, so that a nurse can initiate the order to DC the Foley or initiate the order to call the physician and say, the patient no longer meets these criteria, it's time to remove the catheter. So just one more way to drive forward, getting the catheter out as soon as possible. Next slide. And we've had some real-time auditing aha moments, if you will. One of our hospitals has mentioned that rounding with a clipboard intimidates bedside nurses, and so to move away from that auditing methodology, but more the interactive, observational, team member approach. I have your back, you have my back, I'm just here to help look at what's going on. Introducing yourself, very vital. One of the behavioral expectations we talk about is called the name game, and that's simply introducing yourself and your role. And so we know that when we're auditing data, it's very important to introduce yourself to the staff and to the family and whoever else is present so they know why you're on the unit, they know why you're interacting, and they also have some buy-in as you're giving them interventions that you know what you're talking about. On-the-spot education improves attitudes and compliance. This is versus, you know, mass email distributions or bringing it up into a meeting. If you see someone veering from standard practice, correcting them on the spot and providing the reason why, giving the why over and over again, has really helped drive compliance. And then just back to basic care. Next slide. And so some different audits that we've done, we look for the collection bag being below the level of the bladder, but keeping the collection bag off the floor. And in some of our kiddos, this can be challenging. You might have what feels like yards and yards of tubing to comply with and to keep unkinked and to keep a free flow, but you're trying to keep that bag below the level of the bladder but off of the floor. Making sure the Foley is secured, again, that's a recommended element of ours, but it's definitely something that multiple organizations are auditing for. That the care was documented in the past 24 hours. That is one of those items that you're not going to get through an observation usually, but have to go back in the chart and verify that it's taken place. And then again, that urine has free flow through the tubing with no kinks so that it can't back up into the bladder. So one of the challenges that came up from our organizations, which was really interesting, was transport. A couple of our hospitals talked about the challenge that when you're transporting a patient somewhere, they get moved to a cart or moved to another bed or even moved to a wheelchair, and that bag gets put in their lap or gets put on top of the bed. And so we're breaking, you know, the protocol of sometimes keeping that tubing free and unkinked, but also having that bag below the level of the bladder. And so this came to, the education had to go outside of the nursing units. This wasn't just for nursing and care partners, but it was for everyone involved in the care team, and also to the parents, and knowing how important that was for them to understand why these bundle elements need to be followed all the time and not when we're just in the room auditing it. And so one of our member hospitals actually presented this on one of our, at that time they were weekly calls, and challenged the other hospitals attending the call that if you weren't doing this as a part of transport, tested in your this month in your hospital. So when Vera mentioned that we believe the PDSA improvement cycles is the best practice to help support our key drivers and drive our numbers down, we believe that and we practice that. We're constantly challenging each other as member hospitals to say, here's what we have found, you should probably look for it too, or here's the biggest opportunities we've had, or here's our aha moments, or here's some of our barriers, and here's some of the tests of change that we're doing And if you'd like to do that, here's the information. So we kind of steal shamelessly, not kind of, we steal shamelessly from each other often, because if someone's done it, why reinvent it? And if someone has a tool for it, might as well use it. So it's been really great. Next slide. Another challenge we had was an insertion checklist. Not every organization was using an insertion checklist, and we talked about the power of that. It seemed more accepted when it came to the central lines that we used an insertion checklist or a team member checks an observer to watch you, but not so much with the catheters, with the Foley catheters. And for the hospitals that had implemented this insertion checklist, they were seeing a decrease in the number of CAUTIs associated with insertion. And so talking about the importance of having an observer in the room to stop the line if a breach occurs, and this goes back to that safety story I shared at the beginning around our PICU, their care partner was able to speak up and grab the supplies the nurse needed to make sure she could move forward. It reinforces that proper procedure is followed, and it adds to the reliability by encouraging everyone to keep to the script. And it really highlights the high reliability concept so that you're doing the same thing every time no matter who's in the room. And again, there was just a challenge that we had to go out that if we weren't doing this as a part of the patient's care to test it this month in your hospital. And when we have these calls, we do this often. We'll challenge each other to test different scenarios. Next slide. And this is just an example. I won't read through this to you, but this is just an example of an insertion standard operating procedure. So this was just one institution's example, not of the checklist they were using, but of all the steps and processes that they used that they might have reflected in a process or an SOP. And so again, as we gather these tools from different organizations, we bring them to our learning sessions, we share them on our SharePoint site, we email them out to each other. So if you need somewhere to get started, you really have a whole array of tools to choose from to start somewhere. Next slide. And so one of the other important factors of high reliability is engaging the family. So the most important thing is for the family to understand the importance of those bundle elements to comprehend how they can help keep their children safe. So as I mentioned before, keeping the bag low since they're often in the room more. So just simply explaining why it's important that that bag is below the bladder and what happens if the urine is allowed to back up into the bladder, the risk of an infection. And I think parents, families obviously understand they don't want another infection or they don't want an infection to happen. But they can really be empowered because they're the eyes in the room at all times, no matter who's in there. So it's just engaging them. We involve them at Cook Children's. We involve them on our HAC teams, our hospital-acquired condition work groups, so that they can provide input to the processes. And they can provide input into what really happens in the room rather than what we think happens when we're talking about it in a meeting. And they're also very creative, and they come up with solutions for us that we haven't thought of that are more meaningful to them than we might have come up with in our committee or work group. Next slide. And additionally, on top of engaging the families, we have to engage the staff. And so many of our institutions are using the daily operating or daily safety call. At our institution, I know it's at 9 a.m. Some of the other hospitals have it at 8:30, 8:35, 8 a.m., some even as early as 7 a.m. But it's having a standard time every day that your organization recognizes as a protected time for the leaders in the organization or the key stakeholders to gather and share vital information about what's occurred in the institution and what we predict will happen going forward. So I can speak for how we do this at Cook Children's, and we do have a standard format. And there's a representative from each of the departments outlined that does just that. They report kind of statistics from the prior 24 hours, but then they report if that was red, yellow, or green. Because if I'm reporting statistics for my department, other people may not know if those staffing numbers are good, bad, or indifferent. But if I say we were a red with our staffing, everyone knows what that means. And so we use kind of that as our standard language. And then we predict what's going to come forward. Maybe I had staff call in, so I predict my staffing is going to be red for the oncoming shift. And other areas can talk and help out with that. That information then ideally disseminates back to the frontline staff through unit huddles that take place or departmental huddles. Some areas in our organization have the huddles occur before the daily safety call because they're huddling to get the information for the call. Some of our units have the huddles happen after the call. So more of the frontline care units, the goal is that they have those huddles occurring after the call so that they can disseminate that information to their frontline staff. And then again, the unit, clinic, and team huddles that occur. Next slide.
So next we thought we would just have a couple of polling questions to see what you guys are doing out there outside. And so we'll get the first question. And the first one is, do you have a mechanism to review daily catheter needs? That could include a huddle or charting, an automated trigger using your electronic medical record, or a nurse-driven protocol. And admittedly, probably some of you have more than, and some of you may have more than one, and some of you may have none. So we were just wondering, you know, where people are at this. So if you go ahead and submit your answer. And it seems like the majority of not the vast majority, but you know, more than a third of the people are using charting probably in their daily records. And I know a lot of people, especially with EMRs, maybe having a templated tool in their daily notes or so forth. Nurse-driven protocols, probably tied with huddles there. And we know that a lot of places are using the nurse-driven protocols. It's working very well in adult hospitals, and probably could work just as well in pediatric hospitals. And then the daily huddles, talking about what patients may need their catheters and will not. You know, it's interesting probably thinking about the huddles and who actually are participating in those huddles. Is it the physicians? Is it the nurses, the frontline nurses, probably the ones most involved in the case? Or do you use your infection prevention people as well? I think as time goes on, we're probably going to see maybe more automated triggers being used as a means to seeing, reviewing the daily catheter needs. And then 10% said none. And I think over time, we'll see that that's going to be changing, and we'll see that this is really where we need to be as far as getting rid of these catheters. Next question. That's me again. So for bundle compliance reporting, do you use electronic documentation, direct observations, self-reporting, or multiple methods? And this is looking at, the audits on what you're doing on the floors. And what we see is many, 40% are using electronic documentation, probably which is the easiest for nursing to do. But then others are using multiple methods, and I think a lot of us are doing that as well, both electronic documentation, but maybe having an auditor go out to the floors, looking at the catheters, talking with the staff, talking with the physician teams, requesting whether or not they are thinking about whether the catheters can be removed and so forth. And then 8% are doing self-reporting, relying on the individuals to do that as well. I think that will be it for our questions. And now we will open it up, I believe, for Missy for open discussion.
Thank you, Vera. Thank you, Rachel. Thank you both. So I think we have one question in the question box so far, but if others have questions, please make sure you're putting them in the question box or the chat box, and then we'll call on you. So Sydney, who's our first question from?
First question is from Marta Mendoza. She asked, how do you report your bundle compliance per line? For example, if you have 6 audits, if you have a folly for 6 days and have 6 audits for that catheter and twice the bundle had a fallout, do you calculate compliance 4 out of 6 for 67%, or do you count it as 0 compliance?
So this is Rachel. Yep, this is Rachel. I can answer that question. It's an all or none metric, so unfortunately that would be counted as 0% compliance. Now, I'll say on many, I'll speak for Cook Children's here, on many of our units, we do keep track of each of those bundle elements separately as well so that we know where our biggest opportunity is to improve our bundle compliance, because it's usually one or two elements. But with the way we submit the data to SPS is all or none. So if any part of the element has failed at any point in the auditing process, it's considered 0%.
Great, thank you. I think we have another question. Sydney, who's our next question from?
The next question is from Jan Gralton. The question is, what are the expected reliability metrics used, and how were these metrics collated at the hospitals?
I think you're referring, so this is Vera, I think you're referring to the use of the bundle, and what we're looking at is, and correct me if I'm wrong and not answering this correctly, the use of the bundle and what we used as our standard bundle and elements, and those are the metrics we're using. Each individual hospital may audit differently, which is something that we haven't, mandated that everybody needs to do it, auditing every day or once a week. Each individual hospital decides how often and how they're going to do their auditing. But we are recommending that they audit those specific bundle elements that we just, that we have termed standard. If a hospital wishes to include other things in their bundle, that's up to them as well, and they can do that. Does that answer the question, do you think? Rachel, you have anything else to add to that?
Nope, I think that was well said.
So she responded that that did answer her question. I don't see any other questions in the question box yet. If others have questions, we'll give you a few seconds to put them in. Or you can also raise your hand and we can unmute you as well. Okay, so I think that's all the questions we're going to get for today. So I'd like to thank everybody that joined us today. And before we let everybody go, I wanted to just make sure that everybody knows how to find our operational definitions and prevention standards, as well as our recommended bundles. They can be found on our public website, which is www.solutionsforpatientsafety.org. The picture that you're seeing now is our home page, and from there you're going to click on 4 hospitals. And then you'll see the 3 orange boxes that show up that contain our operational definitions, our recommended bundles, and our prevention bundles. And you can click on those orange boxes and they'll take you directly to the documents that contain that information. So you can see the steps 1, 2, and 3. And I think, do we have another question in the question box? We'll go ahead and turn that over to you, Sydney, real quick before we let everybody go.
We did have one last question. The question was, when can we expect to get the standard clinical indications for Foley catheters?
The ones, I think that Vera and Rachel, once we have enough evidence for those, I think then we would share those on our public website. Is that a fair statement, Rachel and Vera?
Yes, I would agree with that.
I would agree as well.
Okay. I mean, that's our whole point is sharing what we're learning as we go. So with that, we'd like to thank everybody for joining us this afternoon, and I want to thank both Rachel and Vera, as well as our staff here, Sydney and Shaman, who made today possible. And with that, we'll wish everybody a great afternoon, and thanks for your time. Have a good one.
Thanks, everyone.